No more? Thank you, Janet. That was fabulous. Our next speaker is Denise Pugash from Canada. The Early Pregnancy Review, What Do I Need to See and What Should I See? There you go. Thank you.
Thank you. Okay. Thank you very much, Sue and Jan, for inviting me. I'm absolutely thrilled to be here in this beautiful city. It's my first time in Australia, and it's absolutely wonderful. Okay, so I'm the only thing that's keeping you from your coffee break, so we'll try and be brief and succinct and get through this quickly. And this is largely entertaining. We've already established that the fetus is in the right location, it's already viable, and now we're going to delve a little bit further into the first trimester embryonic and fetal scan. I think very often when we're doing a first trimester scan, we're focused on that crown rump length, or we're focused on the nuchal translucency, or establishing viability, and we actually don't look carefully at the fetus. And so I'm going to focus on the fetus and some comparisons with normal and abnormal anatomy. And first of all, we're going to talk about some of the pitfalls that you might encounter in diagnosis. We've already seen one of them that I'll talk about. And then what kinds of fetal anomalies can we start to look for? Some of the cases I show you will be very rare. You know, it doesn't really matter what they are, what the diagnosis is. It's just important to recognize when there is an abnormality. Okay, I think Janet's already shown us a case of this. What is this? Very striking at around 8 weeks of gestation. Anybody know? Rhombencephalon, exactly. Here's the same fetus at 9 weeks and 6 days. You would not believe how many referrals we actually get from people who think that this is an encephalocele or a cerebellar abnormality. And of course, the rhombencephalon is just a fancy name for the fourth ventricle, and it's a stage in development. And as the fetus develops, the brain expands around the ventricle, and so proportionately the rhombencephalon becomes smaller and ultimately becomes the fourth ventricle. Remember that in the normal brain at 12 weeks, the choroid plexus is enormous, and that's because the brain is so thin. And during pregnancy, it's the brain that expands around the choroid plexus, and so there's this normal expansion of cerebral material. Now, this is something, I haven't seen anybody writing about this, but I just wanted to mention it because I've seen it so many times. It always occurs at between 10 and 11 weeks in my experience. What do you think is going on here? Do you think it's normal or abnormal? Who thinks it's normal? I guess you all think it's abnormal. Okay, it looks abnormal, doesn't it? It looks like there's a septated edematous nuchal and posterior thoracic density or septated translucency, and my sonographer measured it at 2 millimeters. But look at the crown rump length. You probably can't read that, but it's 30 millimeters. So it's way too small to do an official nuchal translucency. So what I do is bring these patients back. So here she is at 12 and a half weeks. Nuchal translucency is normal. And on follow-up, and I've got about 24 of these cases now, they have all been normal at birth. Just something I'll mention. So my management now is to simply bring them back for a nuchal translucency scan and base their care on the results of the nuchal translucency and serum screening. Okay, another little point that I'll make is that in the first trimester, we often see something that we want to call a cystic hygroma. And that really confuses the geneticists, because when a geneticist hears cystic hygroma, they're thinking about the second trimester diagnosis, and they will give a dire prognosis to the family. And that is not necessarily applicable in the first trimester. So all we do in the first trimester is measure the nuchal translucency. We don't call it a cystic hygroma. Second trimester is a whole different thing, okay? And I'm not going to say much about nuchal translucency because obviously there is a great deal to say about it, and I don't have time. There are many experts around who can talk about that. And what about fetal sex determination before 14 weeks? Anybody here do it? We have a guy in our neighborhood who claims that he can do fetal sex determination at 11 weeks. We're very skeptical, and we know he makes mistakes. When I first started doing nuchal translucencies, I was astonished to find out that every fetus I scanned was a boy. And then I realized that they all have a genital tubercle at around 12 weeks, and I apologize to all those parents who went out and bought blue clothes. So now I'm very cautious, and I like to wait until about 15 weeks, and even then, sometimes I think it's difficult. Okay, so the anatomical survey at 11 to 14 weeks, we can see lots and lots of stuff, and we're going to talk about that. Some of the common things we see that may not be associated with increased nuchal translucency, but many of these anomalies are associated with increased nuchal translucency. Okay, so what do you think? Is this an abnormal brain? Is there something wrong with the cerebellum? Is there holoprosencephaly? Or is this a normal brain? Any thoughts? Mutter. Well, if you guessed that it was a normal brain, you would be correct. And again, this is the same picture of these enormous choroid plexuses. And the cerebellum looks funny because it's not mature. So we don't comment on the cerebellum really before 18 weeks, as you know. Normal or abnormal? Put up your hand. Who thinks that this is abnormal? Crown rump length. It was a little smaller than expected for gestational age. Yeah, I see. Some people see it. This can be easily missed. This is anencephaly in the first trimester, right? And now that you look at it, you see the cranial vault is just not quite there. Remember that ossification of the skull only begins at around 9 weeks. And so at 10 weeks, there's very little skull present. And you have to be really aware of subtle shape abnormalities in the fetal brain. I actually have a video. It's an old video. For some reason, I suspected, it was early in my days, I suspected that this fetus was going to be anencephalic. And so I brought the lady back each week to do the scan. And each week, more of the brain disappeared and the amniotic fluid became more echogenic. And you could actually see little bits of brain kind of ripping off when the fetus sort of bonked its head with its hand. So there's a lot of destruction of brain that goes on in an anencephalic fetus. Here is a fetus where you can see the orbits. It looks like there's nothing above the frontal bones, but it also looks like there's a very big occipital encephalocele. Our pathologists don't really care very much whether we call it a huge encephalocele or whether we call it anencephaly. To them, it's just a gradation of the same thing. But one of the intriguing things, look at all this brain that's exposed. One of the intriguing things is the fact that the cervical spine is wide open, and this is commonly associated with anencephaly. Of course, it's very academic, but it's kind of interesting. 14 weeks and 2 days. There's a funny membrane hanging off the back of the skull, and this is a cranial meningocele. If you use a high-frequency probe, and this is a very old machine, but we're using a linear 12 megahertz probe and really digging into the mother's side to get these pictures, you can see how the brain is kind of pulled out towards this cranial meningocele. Brain is always abnormal in these cases. It's kind of an interesting case, 13 weeks and 3 days. Normal or abnormal? Kind of looks funny, doesn't it? The choroid's a little bit dangly. The ventricles actually measure close to 10 millimeters. And I think there's a bit of a third ventricle that's a bit big. Let's compare with normal. Same gestational age, choroid plexus fills up the ventricles. So I think there's definitely something going on there. And if we compare the choroid and the normal third ventricle, you can see that this third ventricle is quite dilated. And this baby actually turned out to have a myelomeningocele. Okay. Fetus on the left is the abnormal one. What do you think? Is it acrania? Anybody think so? Abnormal head shape? It's kind of funny looking. Who thinks it's micrognathia? Yep, very good. And that's what this fetus has. And in fact, the diagnosis in this pregnancy was trisomy 18. Okay, let's look at some other faces. Here's an interesting profile. I think there's also a bit of micrognathia in this case, but this is the tip of the nose, and there's this prolabium or prominence, which is actually sticking out farther than the tip of the nose. And those of us who do a lot of prenatal diagnosis know that this is a sign of bilateral cleft lip and palate. So you can make that diagnosis in the first trimester. And this baby did have trisomy 13. Normal or abnormal brain? Who thinks it's abnormal? Stick up your hand. Good for you. Okay. And there's something going on that's very strange, which is there's no developed falx. You can see the choroid plexus is actually fused across the midline, and that's because there's a monoventricle. The thalami are fused, and so this is alobar holoprosencephaly, another fetus with trisomy 13. In addition, this is the same fetus, and of course we look at the facial features. We have severe hypotelorism here and here, shown by the red arrows. And what's this with the green arrow? This is a supraorbital proboscis, which is seen on the profile view. There's no nose, which is typical for a fetus with a proboscis. We can also actually see hands and feet really well in the first trimester, and that's because the fetus does not have the neurological maturity to make a fist. After 15 weeks, it makes a fist. And so when you're trying to scan the hand, it's actually very difficult. But before 15 weeks, the hand's always like this. Similarly, the feet are always in Talipes equinovarus position in the first trimester before 15 weeks. And it's only when the fetus becomes neurologically mature that it can give you that nice right angle. So the first trimester is a great time to look for things like polydactyly, as we have in this fetus. Here we have bowel, which not only is echogenic, but it is poking out into the umbilical cord. So we have an omphalocele, and I love doing 3D in the first trimester. It doesn't add anything, but it's just fun. Note how broad the hands are here and here. Note the supraorbital proboscis. A broad hand is often a tip-off that there are extra fingers or toes. And we have that little bulge of the omphalocele. Oh, that's interesting. Okay. I was heading into part 2 of the talk, but it wasn't supposed to split like that. Okay, so we're going to have to just see if I can zip ahead here. Okay, I'm just going to do it manually. I apologize, I don't know what happened there. Quick review. There will be tests afterwards. Okay, let's hope this works this time. Yes. Okay, so here we have our little fetus again at about 11 weeks gestational age. And I love this. This is just fun. Look at this. This is why I'm showing this video clip. Look at this bright little dot, right? And so this is a normal finding for this gestational age. Here's the still image in case the video clip didn't work. And we see this all the time if you look for it, which of course is midgut herniation, which occurs between 8 and 12 weeks. And that's because the intestine has to go out into the cord, loop around 270 degrees, and then go back in. And of course, we don't want to mistake this for an omphalocele, so we usually give the fetus the benefit of the doubt and wait until 14 weeks before we make a diagnosis of omphalocele. Here's what it looks like histologically with the bowel loops herniating out into the cord. What about this? Who thinks this is midgut herniation? Anybody? Is it normal? Shaking your heads. You're very good. I don't need to give this talk at all. Is this gastroschisis? Yes, exactly. We don't have any kind of a cord or a sac. And so, yes, indeed, we followed this up and it was gastroschisis. What about this? Is this normal? No, not at all. And why is it not normal? Because we've got liver that's out in the cord, and that's not part of midgut herniation, right? We even have a little bit of gallbladder or portal vein. So we can confidently say that that's an omphalocele. Here's a small bowel containing omphalocele. Now, this is a little variation. This is rare, but it's nice to know about. This poor baby cannot get away from the placenta. It is glued to the placenta by something called a body stalk anomaly. And there's a very short umbilical cord. This is the wall of the body stalk. It should be the cord, but it just opens wide onto the placenta. The poor fetus can't move normally, so it usually results in multiple postural abnormalities. And it's just nice to know. It looks very similar to limb-body wall complex. Okay, this is an old case on an old machine, but a thin patient using a nice linear probe that Sue was talking about earlier. This is actually the heart. It's outside. Here's the heart. It's outside. Here's the liver. Here's some bowel. So this baby obviously has a huge problem with its abdominal wall, which is consistent with pentalogy of Cantrell. And you can see, if you can do color Doppler, you can see the heart beating away outside the chest. This fetus also had a prominence of a prolabium and bilateral cleft lip and palate at 12 weeks. And it had a permanent deformity of this foot. Okay, the normal fetus moves a lot, the foot moves a lot, but this was fixed in position. Another thing we can diagnose is hydrops in the fetus at 12 weeks, pleural effusion, body wall edema. Here's a recent case that we had. There are two things going on here. This is a transverse view of the chest. This is the right side of the chest. So the heart is pushed way over to the right side. This is the stomach. It's up in the chest. This is the left lobe of the liver, which actually has some calcifications in it. And the heart is not normal. There's an AV septal defect. So this baby has left diaphragmatic hernia. We offered her a fetal echocardiogram because in our hospital, a cardiac anomaly plus diaphragmatic hernia is a deal breaker. Nobody will touch them, but they decided to go straight to termination. This is a case actually we published a few years ago, not the first case reported, 12 weeks and 6 days. Looks like a double bubble, doesn't it? It's not so much a double bubble, it's a sausage. What can cause this? Well, a double atresia, esophageal plus duodenal atresia, and commonly seen in trisomy 21, which is what this baby had. GU tract, lots to see here. The classic thing that we see is macrocystis, which is a bladder. Sometimes we see a bladder that's 10 millimeters that actually turns out to be normal. This is probably a bit bigger than 10, but in addition to that, the pelvis is missing, the sacrum is missing, and there's only one limb. So this is a case of megacystis with cyrenomelia. Here's another case. The cardiac axis is abnormal. This is the right atrium. It's big. And this is a case of Epstein anomaly, which we followed up. This fetus did not do well. Another thing to really watch for, and I sometimes forget to do this, watch for fetal movement. In the first trimester, the fetus is very active. You know, they go through periods of rest, but then they do a lot of dancing and moving all their limbs. This was a woman who I had scanned in a previous pregnancy, and she'd had an 18 to 20 week ultrasound that was very abnormal. There was a huge cystic hygroma, and there were contractures of all extremities. And so she came for a reassurance scan in her next pregnancy at 13 weeks. And this fetus was not moving. Look at the position of the knees here. They're bent, the 2 feet are together, the elbows are flexed, and both fetuses were affected by an autosomal recessive lethal pterygium syndrome, which was absolutely devastating to her. Here's another woman who came. I had scanned her in a previous pregnancy with the same diagnosis. She wanted reassurance in this pregnancy. Look at the bones, the lack of ossification, the crumpled up femurs, the thorax, which is kind of compressed, these crushed up ribs. And you know what the diagnosis is here. Yeah, osteogenesis imperfecta. She had a D&C, so this is kind of the mashed up specimen from that, but you can see innumerable fractures throughout all bones. At 15 weeks, this patient came for an amniocentesis, and she was actually sent away by the person who did the amnio, and I was kind of watching and I went, wait a minute, we need to scan this baby. And so the sonographer kind of went back and did some more pictures and said, this baby does not have any arms or legs. And in fact, the baby does have arms and legs. They're just extremely tiny. We found a hand. There's no polydactyly. The ribs are very, very short. The chest is small. There is edema around the head. And this is the spine. Now, this is very rare. This is just a curiosity to show you that you can make some rather sophisticated diagnoses with confidence at this early gestational age. And this is a baby with proven achondrogenesis type 2. And the classic thing, the thing that makes you confident of the diagnosis is the complete lack of ossification of the spine. So in conclusion, what I'd like to say about this talk is that ultrasound technology is improving enormously, and it really increases our ability to assess fetal anatomy early in the first trimester. Early diagnosis gives parents more opportunities to come to terms with a fetal anomaly and to have further testing, also to be referred to a tertiary center for diagnosis. And termination of pregnancy, if that's an option for the parents, is arguably safer if it's done earlier. I'd like to acknowledge my research group who has helped me, and I would like to invite you all to come to Vancouver and Whistler for an ultrasound and MRI meeting next March 15th to 20th, which I'm organizing with Andrew New and John Hyatt, and we would love to welcome you to Vancouver in 2014. Thank you very much for your attention. Yes. Okay, the question is in regard to first trimester diagnosis of placenta in creta per creta. And, you know, I didn't want to go over time, and I wanted to focus on the fetus, and maybe I should have focused on the placenta. But you are 100% right. We are seeing it very early. Placenta accreta, we're making the diagnosis with confidence on ultrasound early. And it's always something to be aware of in anyone who has had a cesarean. And the incidence is increasing. It's absolutely crazy. Yeah, so thank you very much. Good point.
All right, thank you very much.